A craniolateral incision is made beginning at the greater tubercle. The incision is extended distally to the lateral epicondyle. The soft tissue covering is reflected, and the position of the proximal main segment of the humerus is inspected. The position of the bone fragments within the area of comminution is examined without excessively manipulating the bone fragments. The position of the distal main segment has to be noted. The insert shows a naked bone specimen with the same fracture pattern. The caudal surface of the proximal main segment should be noted along with the ridge of the medial epicondyle. The intramedullary pin shows the point at which the pin should penetrate the fracture surface and the direction of retrograde pin placement. The pin is driven through the proximal segment and exits the craniolateral surface of the greater tubercle. A bone-holding forceps is placed on the proximal main bone segment. The pin enters the marrow cavity with the shaft of the pin forced against the caudal-medial cortex. If the pin has a single point, pull the pin back to exit the bone proximally and retrieve the pin. The pin is reversed, and the blunt end is driven through the previously drilled hole in the greater tubercle. As the pin leaves the greater tubercle, a small incision is made in the surrounding envelope to allow it to exit. The pin is reverse drilled until the pin point is flush with the fracture surface. A second bone-holding forceps is placed across the distal main bone segment. The proximal and distal main bone segments are spatially realigned. The pin is drilled into the distal segment so that the pin point enters at the caudal-medial surface. The pin continues to be drilled into the medial epicondyle. The main bone segments are manually distracted to re-establish bone length. The bone specimen shows proper pin placement and spatial realignment of the limb. The pin maintains alignment to make plate application easier. The size and form of the plate are dependent on the size of the patient. Various plates could be used. In this exercise, a standard DCP is used. A bending template is used to determine the contour of the bone surface. The plate is contoured to the proper shape and held in position with bone-holding forceps. Using the green neutral drill guide in the most proximal plate hole, a thread hole is drilled with the 2.5 mm drill bit. In this position, one can most often insert a bicortical screw. If the pin is encountered, a monocortical screw is placed. The appropriate screw length is measured with the depth gauge. The hole is tapped with a 3.5 mm tap through the 3.5 mm sleeve. The bicortical screw is placed. A second neutral screw is inserted in the most distal plate hole. To avoid the supracondylar foramen, the thread hole is drilled in a caudolateral to craniomedial direction. The elbow is flexed and extended to ensure that the pin and/or the plate screws do not interfere with motion. Spatial alignment of the limb is examined before inserting more screws. The shoulder joint is rotated internally and externally. Internal and external rotation should be similar. The limb is then examined for proper varus valgus alignment. The remaining plate screws are inserted. If the pin is not encountered when drilling, a bicortical screw is placed. If the pin is encountered, place a monocortical screw. When placing a monocortical screw, it's important not to allow the tap or screw to encounter the pin. Otherwise, if the tap or screw is rotating but not advancing linearly, the threads will be stripped. The tightness of all the screws is checked. Finally, a cancellous autograft is inserted. This specimen shows correct pin placement for a supracondylar fracture. In this case, the pin is initially retrograded through the distal main segment. The pin enters at the caudomedial surface of the epicondyloid ridge. The pin is directed parallel to the medial epicondyloid ridge and exits distally. Spatial realignment of the limb is achieved, and the pin is driven into the proximal main bone segment. The pin will exit at the greater tubercle. The drill is placed on the pin proximally and used to pull the pin into the epicondyle distally.